Oh, yeah.
Am I not close enough?
Is everybody on?
No, we'll like share.
I have with double COVID.
No, totally fine.
All right. That new virus. Yeah. Yeah. No, the other ones.
Yeah, no, I just
We did, but it felt like it was like for the beginning, so. I just saw the other ourselves.
And I think we're gonna wait a few minutes.
Yeah, because the
What time should we?
I just talked to the big boss. Give it a few more minutes. People are coming upstairs, so we're just gonna be a little bit late. But I didn't want you to kick off and then people not here. Right. So give us like 5 more minutes.
I think
yeah. Okay. Yes, thanks.
Hey, Jim, are you recording this as well?
I think it is people. But I'm not from this movie secret.
I
I recognize it. I wasn't sure.
At 2:30. Yes. And then you.
Folks, we're going to give it another 5 minutes as people come into the room from upstairs. So give it another 5 minutes. Thanks.
I think we'll. We don't lose the time. We should run 5
Yeah, we're ready. We're gonna do it.
We'll give it a couple more minutes for people to trickle in. A couple more minutes. Well, hello and everyone, welcome. Take your seats. This will be the best panel of the day. So I'm just setting expectations low. Thank you all for making the time to have this important conversation about the future of healthcare in this country and the future of home health in this country. My name is Mike Botos. I'm a strategy partner. I run strategy, innovation, and transformation for EY Parthenon, which is a strategy firm. Sits within EY, if people have heard of EY. And I work at the intersection, really, of healthcare and public health, in which really interesting conversation today with an esteemed panel of folks across the healthcare ecosystem. You'll hear as they go through their backgrounds that we've pulled together to talk about this very important topic of the intersection of home health and health equity. I'd like to start introductions to my right, your left, with Darcey. Would you like to go ahead and introduce yourself?
Hi, everyone, and thank you for joining what will be, as Michael said, the best presentation of the day and of your lives, right? So I'm Darcey Cobbs Lomax. I'm excited to be with you today. I'm the inaugural director for the Office of Health Equity and Community Impact for Yale New Haven Health System. Within my office, we have a focus and strategy in 3 primary areas right now, which include creating a system culture of health equity, connecting equity and ingraining it in our quality and safety systems, and partnering with community to advance equity. So I think during the discussion today, I'll touch on all of that, and hopefully you'll have some questions that can spark continued discussion across the panel. Great to be here.
Thanks. Hi, everybody. Welcome. My name is Nancy Taylor, and I'm a vice president with Kaiser Permanente. And just out of curiosity, who has heard of Kaiser Permanente in the room? Oh, fabulous. Just about everybody. Integrated healthcare delivery system with just about over 12 million members, and we're in 8 regions across the country, for those of you who don't know. And it's a unique model within healthcare. But my role at Kaiser Permanente is with the National Physician Organization of Kaiser Permanente. So the medical groups in each of our regions come together in one national organization, and I work for them. And within that role, I have responsibility for our social health portfolio in partnership with a health plan colleague. I'm also a vice president over the clinical quality work that we do, so the national quality strategy that we have, and a number of core initiatives in that realm. And then more recently, precision medicine and genomics. So just learning about that at this point. So great to have everybody here, and we're excited for the afternoon.
Okay, so they have me following the big guns. So I'm Christine Lum Lung. I'm a physician. I'm board certified in hospital medicine. I've practiced for over 20 years. I was a prior solo founder and CEO of an independent hospital company. I ran that for 16. And most recently, I'm the CEO and co-founder of Origin Healthcare. So Origin is looking at how we can partner with different organizations so that patients now have the option to receive high acuity hospital level care at home. We'll go into this more, but we launched about 2 years ago. We've treated 1,200 patients in the home so far. So lots of comments about the importance of equity and actually meeting patients where they're at in their home.
All right. My name's Josh Stevens. I'm founder and CEO of Empower Me Wellness. So headquartered in St. Louis, Missouri. My background is in the senior living industry, but headquartered in St. Louis, Missouri. What we do is we rent clinic space in senior living communities, provide primary care, speech therapy, occupational therapy, and physical therapy, as well as laboratory diagnostics services and long-term care pharmacy services. So if you think of independent living, assisted living, and memory care from a reimbursement and regulatory standpoint as the senior's home, it really is. It's an interesting environment to incubate new technologies, new clinical programs, new care pathways to produce better outcomes. So we're in 37 states, have about 3,500 employees with around 1,400 open positions due to growth. Family office backed. So how many founders do we have in the room, by the way? Would love to kick around, how you guys are approaching funding your businesses in this environment afterwards, for sure. So thanks for everybody for being here. Appreciate it.
So we're hoping what you see in this panel is a representation of the healthcare ecosystem. That was what we were going for. We've got payers, providers, home health care, public health, represented CBOs and health systems, all represented at the table to talk about this important issue. Can I just ask, from an audience perspective, how many investors, venture firm, PE do we have in the room? Okay. And how many sort of founders, students or startups do we have? Great. And then how many people that are in health care delivery versus pharmaceuticals, just so we have a sense again. Okay, good. Good. So it's a good cross section, and I hope that helps all of you kind of frame the discussion. Where we wanted to start was a little bit of an overview of how we're thinking about the world right now, and it really is this ecosystem view of the world. Thinking about what has happened during COVID and what we learned during COVID, and what we saw was an acceleration of the possibilities of care in the home. The acceleration of deeper acuity and more complex cases cared for in the home out of necessity, and that is the mother, as we all know, of invention. But it's operating in a silo. All these investments that have been made, the $29 billion of venture funds that jumped into the market around home health care during 2021 alone, and another $25 billion in 2022, the $12 billion in ARPA funding from the federal government to try and enable this, has all created this additional fragmentation of solutions. So you've got some folks that are just focused on hospital at home, others focused on remote patient monitoring and the technology aspect. You got others focused on digital therapeutics. And what we have been talking about is how do we break down those silos? How do we actually encourage collaboration across the ecosystem to drive more innovation? At the same time that's happening, a challenge with home healthcare and moving care into the home is equity. We have a $6 trillion healthcare spending in this country. That's 20% of our GDP, or climbing toward 20% of our GDP. And that $6 trillion is focused on the 20% of healthcare that actually is impacted by clinical care. There are other aspects of care that impact your outcomes just as much as the clinical care you receive. Those are referred to as the social determinants of health. CDC has documented and estimated that 80% of the outcomes that you receive in your life, in your clinical care, are due to these social determinants. And you can see them outlined on the side. It's your behaviors, how you live your life, but also what you do to take care of yourself, but also the food, access to good food, and food insecurity is a big issue, housing insecurity and safety, and other things around your physical environment. As you imagine this intersection of public health and private sector health, the focus, the public health it has on water quality and air quality, that all impacts your healthcare outcomes, and it is driving this growth in healthcare costs. So what we've tried to do on this panel is pull together a group of folks that can talk to this issue from their perspective and help to educate all of you on sort of what they're seeing in the market, solutions to these problems, and problems that don't have solutions. What we're hoping as a panel is to spark some new creative thought, to have people, maybe someone in this audience, come up with the next disruptive business model that's going to help us solve some of these challenges that we're articulating. But that's really how we wanted to set it up, and we had several questions that we wanted to pose to the panel. And the first one I'll just throw out there, and anyone can jump in on it. But as you think about home health care and the growth of home health care during COVID, but then now the latest wave of focus from CMS and others on measuring health equity, what opportunities do you all see at the intersection of home health and health equity?
I'll jump in, and I think from Kaiser Permanente's perspective, we see it even broader than an opportunity. It's an imperative that we bring these two things together. We absolutely saw during the pandemic a move towards home health in a number of different settings, and that had been something that started, well beyond the pandemic, and we had invested in telehealth and various different models of that for many, many years, and we saw that accelerate, particularly in more of the acute care, kind of some of the more innovative places where we believe we have to be able to meet patients where they are and provide for them in that way. That was, before the pandemic, saw it accelerate even during the pandemic, combined with the issues around equity and social factors that also came very much to light even more during the pandemic. So we see these two things coming together and have invested in a number of different models where we're trying to continue to evolve, innovate, measure, understand the impact of these innovations on our patients and members. And the jury's still out on some of them, quite honestly. We're doing some remote patient monitoring work in maternal mortality that we think has a tremendous amount of potential. We have acute care at home models, a number of them that we're testing in different geographies, and believe that ultimately these models will provide higher value. So higher quality, lower cost, and being able to address disparities in care and equity issues. One quick couple of comments on social factors. During 2020, we did a survey of about 10,000 of our members to assess some of the equity and social health needs that they had. And surprising number of them had different issues they were facing. So over 2/3 had at least one social factor, whether that was isolation, food insecurity, financial insecurity, transportation issues. And then we came back in 2022 and surveyed the same 10,000 members, and those numbers had risen a bit. 68% now have one or more, and 20% have 3 or more. And one of the surprising things to me was that this was spread across payer groups. So even in the commercial setting, we have quite a large number of people who are experiencing some sort of social vulnerability. Obviously, it kicks up in Medicaid and other vulnerable populations where, we saw over 90% of our Medicaid population with more than one vulnerability. So when you see these kinds of numbers coming through, the imperative to do something about it, both from a screening perspective and then once you've screened, actually having an intervention that makes a difference for those folks, you see that just rising in stark reality and contrast to what we've been doing historically. So highly, highly dedicated to addressing issues of disparity and equity.
Go ahead, Darcey, please.
One thing I would add to that, and this is something I often speak to our leaders at Yale New Haven about, is that while 20% of a patient's outcome is attributed to what happens within our walls, that we, even though that's small, we still have to address that, right? Those are things that we control because they happened within the four walls of our institutions. But keeping in mind that 80% is a sector that we don't control, right? And so it's easy sometimes to say, well, we don't control the food systems or the transportation systems or housing. However, what I push us and push you all to think about as well is that health systems and hospitals are the biggest citizen in any community. And by that, I mean they wield a fair amount of power and influence and can be a convener of community entities. So I think one of the biggest opportunities from a health system perspective around innovation and how we address the concerns of social drivers of health, or you might want to call them health-related social needs as CMS does, is to really take the perspective of how do we pull together these other structures to create change and move forward, even though we don't control any of those systems 100%, but are really the biggest citizen in any of our towns.
And it's really an opportunity for collaboration with organizations. I had one payer organization tell me that the cost of a Medicaid mom giving birth 6 weeks early is $1 million, which comes in Medicaid right to their bottom line. If they can keep mom going to her prenatal visits and keep her healthy, and she gives birth 2 weeks early, it costs them $12,000. So the business case is there to address social determinants by, hey, I'll pay for your Lyft ride, absolutely. I will get you to that doctor's appointment. I will do whatever it takes, up to $980,000 to keep you healthy, right? I mean, like, it's business, it's economics, which is my background, and it's healthcare. It's how do we actually translate the reality of doing well by doing good? And I think that is what we need to start to think about and Christine, I was interested in sort of your perspective as you were talking about hospital and home and some of the lessons learned from other countries, even that you've seen. I wondered if you wanted to comment on that.
So specifically talking about hospital at home, it feels like it's a relatively new model of care here in the U.S., but I was sharing that it's actually been used successfully around the world for decades in countries like Australia, Italy, and Spain. Dr. Bruceloff says this is one of the most well-studied healthcare delivery models, and yet we've seen some organizations attempt this, and there's some doubt whether or not this will reach scale. As a clinician, it really troubles me that we have such rigorous studies that show significantly better safety, quality, patient experience outcomes can actually finally save the healthcare dollar, 30 to 40% savings, and yet we're struggling for that to take off here in the U.S. And I think it should make us all pause and ask why that is when we have something that repeatedly shows benefits. And I am concerned that we don't have the payment structure aligned in the right direction here for us to achieve equity. And I definitely think it's something for us to talk about, but we need to start holding each other accountable. And everybody needs to give a little bit to the point of it makes logical sense, it makes economic sense, and yet people have not stepped up to fund it. We don't have the incentives aligned in the right way. There are systems and payers who look at a one-year ROI on any innovation, and when you're talking about equity, while I believe that you can see some ROI, I think we also have to set a realistic landscape for this too. So we have models out there. We know it's the right thing to do. We have to figure out why we can't close that gap still. And I think that's something that goes back to the imperative of it. We can study this all we want. There was just a study that came out of Yale recently that was talking about some of the inequities. We know this is out there, and now we need to start figuring out how we're actually going to implement some change. And that's the reason that we're here as well too, is should that come from the traditional institutions that are in healthcare, or is there an actual, private-public partnership that would be better at achieving this?
This is one of the biggest opportunities for innovation that we will see in the healthcare industry in a long time. The costs of health disparities, the waste in our healthcare system, have been estimated by IHI at $150 billion, and that's probably a low number right now. Just because these disparities, the issues that I just described, that number is anticipated to grow, waste in the healthcare system, to $350 billion by the year 2050. These are big numbers. These are big problems to solve and big opportunities for innovation. And Josh, I've been so impressed with your business model at Empower Me Wellness, and I wonder if you could talk a little bit more about that and how you're actually doing well by doing good.
So I think, just to jump off some of the things that you all have said, a lot of the advantage we have in our environment is time and exposure to build trust with the population that we serve. What I think that allows us to do is experiment with ways to move from episodic to more longitudinal care, right? And engage the clinical workforce that ultimately is the deciding factor on whether this is going to succeed or fail into the outcomes. So, utilizing tools that are already in the Medicare toolbox, for instance, like principal care management, chronic care management, and applying it to the environment that we serve and getting the frontline clinicians engaged and excited about that longitudinal relationship versus just like this intervention mentality of something went wrong yesterday, so I better call their doctor. And managing a lot of the health behaviors up there is what we're really, really focused on. When you look at, I think, the pandemic, just to go back to that point, the adoption of technology by the frontline providers, and really it being not forced upon them, but that was the only way in many situations to deliver care. The other thing, just to mention, I think that has to be talked about insofar as health equity is the workforce generally for home care. And how do you engage a workforce that this is the environment they want to deliver care? Because more than ever, they have control over where they practice or where they care, for patients. And fortunately, we're seeing that we can create a win-win especially in rural environments, for the workforce inside of the home care environment in a lot of different ways. So, those are just some of the things that we're pursuing. It's workforce engagement, it's technology, it's really meeting the patient, the resident, we call them, where they're at with true person-centered care, investing the time into getting to know who they are, who their family is. The family support has a big influence on which way, a resident, or kind of what kind of outcomes you see from them.
There was a study that was just published in Health Affairs. No, it was the Commonwealth Fund just published a study done by the University of Chicago. A woman named Lauren Salisbury, who analyzed the uptake rate on home health care and the adoption rate of individuals, and found actually Medicare beneficiaries of color were more likely than white beneficiaries to use home health care, to actually use the whole home health care benefit. And what they also found was that home health care that they were getting was actually more from caregivers, from friends and family, and informal versus formal, using Medicare benefits. It was they use home health care, but it isn't through Medicare. It's not reimbursed. They're just getting care at home from a family member. And the reality of that is a variety of factors that cause inequity for that individual. They don't get the same probably quality of care. They don't get the same access to other aspects of care that individuals on Medicare, other individuals that are actually benefiting from the Medicare opportunity get. And if I will say that on this diagram, as you kind of think around the circle within home health care and all this fragmentation, there is this piece down at the bottom on integrated health data platform. Some way of integrating this data or bidirectional information sharing is something we talked about, demonstrating outcomes of those that are actually getting the home health care. Have any comments on that from the panel?
Just to comment on the point you just made, I just got a pre-draft of a journal article that's going to be published in the Journal of American Medical Directors, and what they found on the utilization of telehealth for primary care in the African American population in my setting, it actually went from, it leapfrogged the white population by the end of the pandemic. And I think it's because the care gap was so identifiable and solvable, right? And so, so that I just wanted to raise that point. We're seeing, in some ways, the deeper the need, the more willing people are to consider, a lot more solutions rather than say, I actually already have a primary care doctor. He only sees me once every year and a half. But I don't want to switch to something that might be, more effective and more accessible. So,
yeah, and we're seeing major challenges in terms of trying to integrate the data and capture both where we are and how we move forward in this space. So 8 different regions. We've got at least 8 or more different instances of EPIC. They all capture race and ethnicity differently. So we're moving towards a single way to, the OMB sort of single question of capturing race and ethnicity. But that just getting agreement to do it was the first step. Now we have to actually implement it. So we're months, if not years away from having streamlined that. Then, in addition, lots of infrastructure needed to actually capture social determinants, integrate it into the various different versions of EPIC that we have, trying to create some ways in which clinicians can engage with that social determinants wheel, if you will, so working with EPIC on that as well, and they're doing some good innovation in this space in that regard. And then, we've also, all of our major quality initiatives for the organization, we have agreed to segment those by race and ethnicity to understand and put targets out for ensuring that we're providing highly equitable care across all of those different quality goals, which are some of your basic HEDIS measures, but then go far beyond that. So have set that in place. And even that segmentation has taken months of work to ensure that we've got technical specs that everybody agrees on and is comfortable with, the fact that we're comparing apples to apples across the program. So huge investment to get it right.
And to be able to demonstrate outcomes then at the end of the
That's the goal, yeah. And I think Darcey and I have had some conversations about early outcomes that we're seeing related to people's comfort level with care in the home. And we don't have definitive information on that yet, but early signs. And we've got a number of outcome studies, particularly the maternal mortality remote patient monitoring program that I mentioned, which is this sort of blended model of you can do virtual care or go in for care on any given visit, and we provide them with a Doppler kit, or a Doppler device, a blood pressure monitor, and an app that kind of helps navigate the kind of perinatal program. But I don't know if Darcey wants to comment on that.
So I would just say, too, I think that there's what we have to measure right now, and then we also need to keep our mind open because this is a very new space and going into the home. With patients and with caregivers, we need to be very open-minded about what is important and impactful for them. So we're trying to measure anything and everything we can. And we were discussing earlier, too, that in the home, the power dynamic has switched. Patients and caregivers feel more comfortable and they're sharing insights, struggles that they probably wouldn't have otherwise. And so how is it we're capturing what it is they're saying and having that translate into something meaningful and actionable? So I think there's a lot still that we're going to learn in this space.
Darcey, did you want to comment on
Sure.
Nancy's point? Or?
I have a little bit of data I'll share. So we have a hospital at home or home hospital initiative, and what we recently found as recent as last week is that 15% of our Black patients are declining to have their care delivered at home. And we're not really sure why, so we'll be doing a root cause analysis to try to figure that out. But one thing that I'll say about data, I say this a lot to my colleagues, is that data tells a story, but the community will tell us the truth. And so my perspective is I come from a community health background, and my education allows me to see this from both a public health and a business perspective. But I do think one of the biggest opportunities, which I know leads into your second question, is that I find that most of us don't really understand equity, or we can define it with a textbook definition, but struggle to identify inequity. And that includes myself sometimes. I can easily spot it in some places, and sometimes I can't. And I was asked a few years ago what my pie in the sky dream was for our health system, and my response was that we would make every business decision from an equity lens right down to who we buy our Band-Aids from. Right, so it goes right into supply chain, it goes into how care is delivered at home, it goes into finance, it really sits everywhere. So getting it spread across a large health system or even a small one is difficult. So to kind of go back to the community telling us the truth and kind of connecting the dots here is that being in the home just gives us a frontline view of what the screening tool doesn't give us. So the screening tool said there's an issue of food insecurity, but you get in the home and you realize there's also, extension cords running everywhere because they don't have the correct power outlets. There's all kinds of frontline view that we get in the home that we wouldn't get otherwise. And then taking that data and putting, as you said, the power in the patient's hand to really be co-partners in how the care is delivered can really help to improve outcomes for us.
And how are you, Darcey, dealing with this workforce issue? Because I know that I know you've had a hospital at home and a post-acute care strategy for a couple of years. Have you cracked the code on that? And maybe the other panelists can comment as well.
So I don't think we've cracked the code, and I'm not as involved in home hospital as a speaker we had last year, Dr. Akande, but we do cover services in the home, both a little bit with our own employees, but also with contracted services. Additionally, as a health system, we've invested largely in community health workers during the pandemic through hospital funds as opposed to grant funds, and we're deploying them into the home and across community really as what I call my equity eyes and ears on the ground. Right? I can't be everywhere, but they are out and about on a daily basis, and because they sit within the Office of Health Equity and Community Impact, they really bring back the information that our most senior leaders would never get to have, or that I would not get to have, because they are in the home and they are on the ground with the patient. So, but that takes time to pull that qualitative information together to really come up with the appropriate strategies. But we're well underway with that work at Yale New Haven. And one thing I often say is health equity work is forever work. It will long exceed my time and my role here, and probably any of us, because we have hundreds of years of inequity in this country to really try to overcome, well, to first understand and then overcome.
Josh, did you want to also comment on the staffing challenge you brought up?
Yeah, so in August 2020, when we spun Empower Me out from my prior organization and decided to really double down on growth, we had 100 employees overall and 9 in our corporate office, right? And we should end this year at around 5,000 employees. And I think embedded in your operating model to attract the workforce of today and probably over the next 10 years has to be culture. It has to be reinforced inside your operating model, and you have to be able to identify what you're spending on your core values. You have to be able to link all that to patient outcomes. And so, like an example of, I think, what a couple examples of ways that we've found to meet our employees where they're at, so they can meet our patients, our residents where they're at, is very flexible scheduling. They are in charge of scheduling their appointments with their patients. And that might be on a Saturday or Sunday. It might be utilizing telehealth. So really pushing clinical judgment back to them to make sure the encounter actually occurs. A real rise in, I think, in the last 6 months or a year in burnout from hospital systems and on the mid-level provider standpoint with nurse practitioners wanting to be at home and do a lot of remote care coordination. Fortunately, that's been met with CMS really pointing the industry towards that with RPM and RTM and CCM and PCM and all the M's. So, really trying to just be flexible. People don't want to commute for 45 minutes. They want to be close to where the patient is. That's a benefit of home care. It really is kind of a sad commentary that you have folks in St. Louis, for instance, commuting on 3 different buses for an hour to get to a hospital to care for somebody when that person oftentimes is sent from down the street to that same hospital. They could be cared for by Christina's company, at home using somebody in the neighborhood. So, yeah.
It goes back to what we're talking about with equity. I think, in order to have an equitable healthcare system, we also have to have a system that's sustainable. I think we all worry about the sustainability of our current healthcare system, so we need to rethink that. And in the same way, we need to rethink how the workforce is participating in healthcare. So a two-pronged design. We'll see as we get bigger in scale, but we find that we actually have people that are gravitating towards us that would maybe otherwise leave healthcare. They're not wanting to leave healthcare because they don't want to care for patients still. The healthcare system right now is just not set up to honor why they went into healthcare. So what do we need to do from a system redesign, a care delivery redesign to really get back to honoring that? Anecdotes from our staff so we have nurse practitioners, nurses in the home, physicians on telehealth. Our team, people would say that seems weird going into a home. It must be very uncomfortable. They love it. They love being able to see the grandkids' pictures on the refrigerator, the fishing trophy on the mantle. It really allows them to connect back with the patient. And so one quick anecdote, we have a nurse who works with us and works still some part-time shifts in the hospital. And her daughter says, I can always tell the days that you work with Origin because you come back happy, and I can tell the days you work in the hospital. And so we need to redesign this so that every day people come back from work and they feel fulfilled.
Just a quick story. I think versatility is another thing that the clinical team in the home setting wants. We saw a care gap with residents not getting their diagnostics laboratory services because of transportation issues and such, and asked our therapist, would you get cross-trained as phlebotomists so we can collect these specimens on site? And we expected them to say, absolutely not. We went to school. We have DPTs and, doctorates in therapy. And we were surprised when they said absolutely, and we had a line out the door. So I think to your happiness point, caring for a smaller population, but deeper, and following them all the way through the journey is, what we found to be something really rewarding and helpful for retention and all the things that matter.
Well, let me ask a question. It's sort of open-ended, but if you could each think about your personal vision for the future of home health and maybe this intersection of health equity, and then problems that you'd like to see innovators in this group solving, that would, I think, be a really interesting conversation for the group to hear. Maybe if you have, think about your vision, and then, what is the biggest problem to be solved?
There we go. Yes, it's working. One of the things that we talk a lot about at Kaiser Permanente are the health behaviors. And I think, I've often said that it's sort of the holy grail of healthcare in general. And so how do you change habits? How do you educate people? How do you get folks aligned with and carrying out any recommendations they may be getting from a healthcare provider, but also sort of doing stuff on their own and taking that piece forward? And that's got to be something bigger than just the healthcare system. And I think a component of that is rising to the top and kind of falls outside of this panel a little bit, and it's actually the next panel, is around mental health as well. And so being able over time to truly address and align incentives and do things to help address health behaviors at the core, I think that'll do as much to improve health as anything else. That, and if anybody can solve all of the kind of infrastructure, data, interoperability stuff, that's just such a huge headache. So even just helping that around the margins is enormous.
If I had a magic wand, it would truly be to say, let's just blow up everything that we know and start from a clean slate. And let's put the patient at the center, and let's say, what does the patient need, and how can we best provide the services for that patient when and where they need it the most? A lot of what we're doing is we're so tied to, the current structure, the current legal system, the current payment system. It's really inhibiting our ability to truly think creative in this, and I would love a clean slate and to start fresh, because I don't think it would look like what it looked like now if we could start from a clean slate.
So I think, where we want to get to is that everybody has a companion on the journey, a competent, educated companion that's incentivized towards the outcomes of the population that we serve and the individuals that they serve, and that is aware of all the tools that they have access to. It's just remarkable from even 2 years ago when we began our journey to now, how much more we are aware of the tools and resources that actually exist to serve the population. And, staying on top of that is one thing. And so I would envision, a demystified future where the patients actually understand and have visibility into what awaits as they age, right? Interoperability is, EY did an engagement for us, so Michael's seen it. We have, 26 different EHRs. We're interacting with over 1,000 senior housing communities on a day-to-day basis. They have, 75 different EHRs, hundreds of different hospital systems in the mix, and that's something that I think can only be solved perhaps by a uniformed approach that kind of defragments the access to all this data. Because at the end of the day, it's our opinion that the patient owns the data, and it's up to us as a system to use it to their benefit. From an Empower Me standpoint, we have 20 million seniors within driving distance of our clinics, and we really want to turn into the hub of a hub and spoke senior care model where we can enable the single-family home experience in a way that somewhat mirrors the senior living experience from a supportive environment perspective.
I think one thing I'd add to that, if we could just start over, and if money weren't an issue, I continue to go back to the community members' voice, whether that's the patient or our employees or the people who live around our hospitals. I just think I know there are solutions. I've seen it time and time again with small projects and even larger ones, that those solutions sometimes exist in outside of our walls. I want to speak to, I think Josh mentioned trust earlier today. There's no shortage of literature on the distrust of our healthcare system. And so how do we make that shift, right? So we're currently doing listening tours across every one of our delivery network communities, listening to community members tell us what they love about us and the things that they, wish we'd asked these questions years ago as we've acquired other hospitals, and we've heard things that make us feel great, and we've heard things that have made us cry about how care has been delivered in some of our communities. So I go back to the community members' voice and perspective and lots of the solutions sitting there. I do think we need IT solutions, in particular with community-based organizations that don't have the financial resources always to invest in an electronic medical record or even a platform like Unite Us or not NowPow, but with Find Help. So those are two big ones across the United States right now. But CBOs, from their perspective, often don't have the financial resources to even be our partner on the other end as we make referrals or have the capacity to service the referrals that we're sending out through these platforms that aren't quite closed-loop platforms. So there's probably 10 other things I could name, but those are what are top of mind at this moment.
So looking forward to this group coming with solutions, a bunch of innovators, and hoping to do that. I guess one thing I'll say, and I'd like you all to comment, is that as I think about that gray box on this chart of the social determinants of health, the 80% of healthcare, a lot of those things are kind of in the domain of public health. Tobacco cessation and a variety of different transportation, income, air, and water quality. How do you think about the role, as you talk about CBOs and the role of enabling CBOs, the role of public health, and sort of how we think differently about public-private partnerships going forward? And that can be for anyone. I'm just picking up on your CBO comment.
Well, I think we have to give community organizations space to take the lead on that. And it's hard. It is hard for health systems and hospitals sometimes to do that because we're used to being maybe in control. We probably have the most money in the room. We've got the largest voice. We've got the most resources. We've got Yale. We've got, PowerPoint. We've got, all the things that sometimes, small CBOs don't have. So I think it's a retraining of our brains as leaders sometimes just to show up. Right, and to give that power, if you will, to CBOs to be a partner, and I think that is a learning for us within our health system. And sometimes we do it well, and sometimes we fail. I think that's the case probably for many of us from the healthcare perspective. I think, and I don't sit in the government space, but we have some great community and government relations folks at Yale New Haven Health, but I think pulling in the government relations and the policy piece of work really is important, and it's important to have a really good team in that space, and to really lean on those folks, especially from the public health perspective.
And I'll jump in as well. Yeah, so the work that I'm involved in is so much more focused on the what can Kaiser Permanente do about it part, and there's this vague sense of discomfort on, okay, and we're handing these over to the CBOs. Have we really validated that they're going to be able to manage this additional, essentially, volume of people who have the needs that we're sending to them? And not great answers to those questions, to be honest. And it happens a little bit in two different parts of the organization, right? So we're building infrastructure to screen, because that's what we were going to do it anyways, but now all of the different regulatory and accreditory agencies are saying, we need you to start demonstrating that you're actually screening for social health factors. Okay, great. And then what we've actually already started to pivot to is, and then what are the interventions that we're providing for those folks? Of the ones who stand up and say, yes, I want help, what are we actually doing for them? Then that handoff piece is the part where it's far more vague. And there's, our community health organization, our community benefit organization, a big part of Kaiser Permanente, invests back in and provides support into the communities, but I'm not convinced it's done in a strategic and an aligned way as possible. In addition, we've launched a coalition with Alliance for Community Health Plans and AHIP and the American Hospital Association and the American Medical Association to sort of make this point about investing back into the public health infrastructure with CBOs as a component of that. Where and how that leads, much yet to be defined, but it's a huge missing piece as part of the conversation.
Yeah, absolutely. And so I'd like to open it up to the audience. You've heard a lot about how we track outcomes, about how we enable CBOs and community-based organizations with tools, how we enable data interoperability, how we solve workforce and staffing challenges. What questions do you all have? And maybe we can pass one of the mics around and just have any questions that are on top of your mind, if what you were hoping to hear that you didn't hear us discuss yet.
I'm going to take the first question since I have the mic in my hands. Jim Boyle, Yale Ventures. Christine said something that I wanted to recognize. She said, aside from blowing up the whole health system completely, I think it was thinking about
metaphor. Sorry.
Yes, it's okay. Thinking about time frames. A couple of years ago, I was leading an innovation workshop here at SOM with executives from Latin America, and I asked one of the executives, "Oh, you're running an innovation group. In what time frame do you have to demonstrate that it's successful?" He said, "What do you mean, what time frame?" And I said, "Like, how many years do you have?" He looked at me silly. He said, "Like, this year. It has to work this year. I have to have ROI this year." So my question for the panel is, short of blowing up the whole system, what if there were a more patient class of capital that you could have to demonstrate success? Because some of these things, to Darcey's point, there's some induction time it takes for these things to work. Any thoughts?
100%. We need a different source of funding for this, whether it's external capital. And, we've heard from people in venture, we're talking about healthcare delivery, which for a lot of venture isn't considered super sexy. Although I would argue, look at Oak Street and CVS, there's some sexy money in 10.6 billion. But and so I think it's a collaboration of across all. I think the healthcare system will need to give some. I think private's going to need to give some. Payers will need to get some, and I think we need external. But I think your patience is 100% what everyone is going to need to have in order to achieve this. It's just, unfortunately, when people are making decisions, they have to return money to their investors. They're, responsible for delivering outsized returns. We saw what happened to Southwest, right, with their technical debt that they just get. At some point, this will explode, and it's never going to get easier to make this change and make those decisions. We need to do that now.
Thank you very much, Christine. Any questions?
I have a question for Mrs. Taylor, I guess. I'm one of those people who actually didn't know Kaiser Permanente before, but you are an insurance provider too, right? So I heard in the panel before that you want to bring like sensoric devices into people's home to provide equity. And I'm just wondering, is there not like a conflict of interest sometimes? Because you're actually analyzing a lot of data, but you also have economic interest. And I'm just wondering about how you keep basically the data safe from yourself so that you're not going to analyze it and, provide like a different, or deny insurance or like provide different costs to different, risk factors, like people with different risk factors, because there would be the opposite of equity.
Great question.
Do you a softball?
Yeah, exactly. Gosh, great question. And I think the question of data and patient privacy and how Kaiser Permanente takes care of that data has been around for Kaiser Permanente since its inception, because the way we're organized is as both a provider of care and an insurance company. And so there are a lot of safeguards that are put in place as it relates to that. But and I don't know that I can speak exactly to the specifics of how we do that, other than to say that as a person who's worked for the company for 20 plus years, I don't ever see it coming, the data being used in the ways that you're talking about for those kinds of purposes. We tend to be very cautious about data uses and privacy and keeping track of those components. I think it's what the value add is actually so significant here, in that if you can separate the insurance and sales side piece of it, but be able to have the kind of data that we have on patients that's highly longitudinal, right? Our patients tend to stick around for 15, 20 plus years. We have a lot of people who were born at Kaiser Permanente and continue to be members throughout their lifespan for many, many years. That's where you get the alignment of the preventive care kind of being able to then translate into improved health overall. So, it hasn't come up in the way that you've been talking about it.
Any other questions? Yes.
Hello. Great panel. Visagan at Agent Capital, but also quite passionate about remote patient monitoring in the post-discharge setting. If there's the possibility of an at-home test that a patient can do for themselves, how would payers, or what would you consider as a good reimbursement model there?
Like a diagnostic test, like a lab test, or what kind of test? Like, because Cologuard is an at-home test, right? Are you talking about like blood diagnostic?
Maybe tied to the chronic condition management. If there's any learnings from like blood sugar or blood pressure, I'm just curious about, how payers would see that.
I can speak to the answer.
I
was going to say most of the payers when we look at it, if it's anything diagnostic, the way the model is built today is it requires longitudinal data head-to-head. So unlike a medical device or a pharmaceutical product where you get FDA approval and most of the time the payers pretty quickly pick it up with a CPT code and decent coverage, for diagnostics and lab tests, even if you're an LDT and you want coverage, you're looking at probably 3 to 5 years of longitudinal data with probably thousands of patients to get a decent reimbursement rate.
Yeah, so, we anticipate deploying, let's just say 100,000 RTM and RPM devices over the next 2 to 3 years. And the payer that we're comfortable with dealing with is CMS, because everybody else doesn't have the risk tolerance to really serve as distribution. So, to the point where you really got to just decide how you're going to market it to the patient population. We're in a fortunate position where about 65% of our residents are straight Medicare beneficiaries and not on Medicare Advantage yet. So we can take the time to collect the outcome data that she was talking about to justify the reimbursement rates. But we're happy with getting into the game from a longitudinal standpoint by using RPM and RTM and letting the outcomes kind of catch up with the distribution.
Okay, hard stop at 2:30. One more question, quick answer.
Hi, I'm Ryan. I'm an undergrad. Basically, something that stood out to me was, I think it was Darcey who said that data can tell a story, but like the communities tell the truth. I think that my question is, how do you go about building trust in those communities when you're doing interviews and talking to people who have, in some cases, been historically like marginalized, and how do you go about reaching out and building trust in those communities?
Sure, great question. So one of the ways that we've approached that is just starting with people that we know, that we have a good relationship with. And from there, just showing up and listening. We come with our own questions, but we listen to what they want to tell us as well. Additionally, we are providing stipends to community members. We see them as consultants with real answers to our problems, the same way we pay consultants large sums of money to help us with strategy, right? So that's new for us. We have not been doing that for many years, but it is a gold standard across the United States. And it's really just kind of just being present. And also, you have to do a good job of telling your story. Like sometimes we hold back our stories of what the great work is that we do in the community, so we don't even tell community members. And then the assumption sometimes is that, well, you're not doing anything. So there's a lot of pieces to it, but the biggest thing is to be a listener. And so the model that we have is listen, learn, respond. So we listen, we take that back, what are we learning? And then we try to come back with a response, which is not a yes, we'll do everything you say, but here's the one thing that we know we can do, the one small change. We can make sure the lawn